So I'll be talking a bit about diagnostics and therapeutics of APOL1. Of course, too broad a topic to do justice in 20 minutes, but I will give an overview as many of my colleagues have. I'll introduce my disclosures here, a consultant for certain entities. And so I thought what I'd do is discuss some cases that really illustrate the diagnostic and therapeutic journey that a lot of our patients face. The first patient I'll discuss is a 35-year-old woman of recent African ancestry with a history of hypothyroidism, uterine fibroids, gastrointestinal reflux disease, and she's regularly followed by a primary care physician. No history of hypertension or chronic kidney disease. GFR has been consistently more than 90, and the patient performed a 23andMe DNA test and uploaded findings to her electronic medical record, which really is a snapshot. Again, not the full report showing G1, G2. You have both of the genetic variants we tested, and of course was a bit alarmed, right, by this finding, and reached out to her primary care physician to really clarify what this actually means. And the PCP just, of course, set up a nephrology consult, and the nephrologist also reached out, to our group just to ask, does this patient have G1, G2? Is there a higher risk for CKD? How should this patient be managed? And really, again, highlighting the widespread availability, right, of genotype for APOL1 testing in the general population. So it turns out that even though this patient had been getting annual EGFR tests, she never really had urine protein or albumin quantification, right? In the U.S., we don't have a general screening program for CKD in the general population, and certainly urine testing for albumin and protein not routinely done at annual physicals. Even though she had a urinalysis incidentally 3 years prior that had 1+ protein. So at the nephrology visit, again established no family history of chronic kidney disease, even though the information was not complete for the family history. Her blood pressure was normal. She had urine protein creatinine ratio that was within normal limits, and really normal kidney structure features found on CT of the abdomen and pelvis. So this patient was reassured, encouraged to follow up for annual kidney testing. Second case study is regarding a patient who was in two consortia that I'll talk about, the GUARD and KPMP consortia. 65-year-old African-American woman, again, history of hypertension as well as hyperlipidemia. And this patient was in a GUARD study that was initiated at my institution, Mount Sinai, and has since expanded to several sites around the country. And it's really a pragmatic randomized trial of genetic testing for APOL1 and pharmacogenomic predictors of antihypertensive efficacy in patients with hypertension. So as a part of this study, eligible individuals who are of African American ancestry, who have a history of hypertension and followed at a primary care clinic that was enrolling for the study, are randomized to control and intervention arms that are really centered around educational material and baseline surveys, but also genotype testing for APOL1, which is done either in a delayed or immediate fashion. So you can assess the impact of return of results for APOL1 testing on patients, their follow-up, their attitudes, their behavior towards their health care in general, as well as attitudes of physicians who might, again, get the APOL1 genotyping results, again, in an early versus delayed fashion. So it will be very illustrative to see how patient and provider behavior will change based on the results. And there's a pharmacogenomic sub-study as well that will evaluate the relationship of the pharmacogenomic genotype with change in blood pressure between baseline and 3 months, really testing the efficacy, again, of thiazide, diuretics, and hydralazine, which might be impacted by certain pharmacogenomic results. So again, a number of sites are participating in this study around the country in the U.S. This patient had a blood pressure on a recent evaluation, 117/76, really taking losartan, angiotensin receptor blocker, as well as amlodipine daily. Her estimated glomerular filtration rate, 56 to 59, putting her just within the CKD3 stage, again with really normal urine protein creatinine, urine albumin creatinine levels. Patient has APOL1, G1, G1, high-risk alleles. And so she qualified for another study that we were participating in at Mount Sinai. I know Afshin and others from the NIH are here, the Kidney Precision Medicine Project, right, which again is a multi-year collaboration to study patients with kidney disease to better understand the mechanisms underlying acute kidney injury and chronic kidney disease, including diabetic kidney disease and so-called hypertensive kidney disease, a large component of which in patients of African ancestry would be APOL1 related. So again, overarching goal to identify new treatments for kidney disease, ethically collecting kidney biopsies from participants who meet the inclusion criteria for AKI and CKD, and ultimately to develop a kidney tissue atlas, define disease subgroups. So we are a recruitment site for this project. So the patient had a research kidney biopsy. Again, we wouldn't normally perform the biopsy for clinical reasons, but in this case, the biopsy did show focal global glomerulosclerosis, about 5% of the glomeruli, some mild tubal atrophy, interstitial fibrosis, mild arterial sclerosis, and representative glomeruli, though, really are normal appearing, and the pathologist did mention that the changes really are within the range expected based on age and the sampling of glomeruli that were obtained. So the patient really was recommended to continue the current antihypertensive regimen and is undergoing regular follow-up. Case 3, spring of 2020, as we can say. We know what was happening during that time, really the peak of the COVID pandemic in New York City. We saw a 53-year-old African-American female, past medical history of hypertension, hypothyroidism, really no prior history of kidney disease, though, hospitalized with acute kidney injury, nephrotic range proteinuria in the setting of confirmed COVID-19. Admission labs revealed elevated inflammatory markers, interleukin-6, IL-8, TNF-alpha, C-reactive protein, etc. And serologic workup, right, for alternate etiologies of glomerulonephritis were negative. The patient required hemodialysis, so severe was the acute kidney injury, and in-house APOL1 genotyping confirmed the presence of G1, G1 high-risk alleles. So, there certainly are a number of DNA-based PCR genotype testing modalities available now to confirm APOL1 high-risk alleles, and this was one paper from Mount Sinai in 2016, really validating our in-house test in 48 positive and 10 negative controls, concordant with Sanger sequencing, and the group at the time also expanded the validation to over 7,000 DNA samples in the Mount Sinai BioMe Biobank, really used for multi-ethnic APOL1 allele and genotype frequency screening, and really consistent with published results. High-risk alleles were present in about 14%, right, of African-American individuals, very consistent with what we're seeing in the epidemiologic data previously presented. So this patient's biopsy, again, represented collapse of the glomerular tufts, really another glomerulus showing the capillary loop with proliferation of overlying epithelial cells, electron microscopy showing diffuse effacement of the foot processes, really this collapsing glomerulopathy that's been well described in patients with COVID-19, high-risk APOL1 alleles, again, presented by other groups as well. We found incidentally, as has been reported, that APOL1 staining in patients' biopsy tissue with the collapsing glomerulopathy in the middle showed a reduction in expression level of APOL1 by immunohistochemistry, similar to what again was seen for HIV-associated nephropathy. So again, not completely consistent with what we think about an upregulation of protein expression, but again, this has been reported. We also showed then in that case report that phospho-STAT3 expression and the glomeruli and the tubules, again, upregulated in this patient with a collapsing glomerulopathy, consistent with what's been reported in the pathogenesis of HIV-associated nephropathy, potentially again showing some concordance in the pathogenesis. And, I mentioned Juan Carlos Velez and others have published a case series on the collapsing glomerulopathy. This was one from New Orleans, where, again, they showed 6 individuals with the APOL1 high-risk alleles who got this collapsing glomerulopathy, really associated with the cytokine storm. Doing nanostring extraction, we're able to show chemokines and other inflammatory markers upregulated in the kidney tissue. Really no direct viral infection was established. Interestingly here, for the establishing of the high-risk genotype for APOL1, DNA was extracted not just from peripheral blood, but in some cases from the renal biopsy tissue. So, of course, that's another way that APOL1 high-risk genotype can be established. So another way is reported by LabCorp, and thanks to Barry Friedman for pointing this out to me at the airport yesterday morning. But again, most labs do perform DNA sequencing for APOL1 to identify the nucleotide polymorphisms, but LabCorp does have a mass spec-based approach to determine the APOL1 phenotype by detecting expressed mature proteins, right? So the results, of course, of the protein readout can differ from DNA sequencing due to patient-specific transcription translational differences. So case 4, this is really centered on treatment, which we'll spend the rest of the time discussing. So this is a 64-year-old African-American woman with hypertension and diabetes, hyperlipidemia, referred to nephrology after proteinuria was discovered by her primary care physician. The patient had been complaining of foamy urine, and so her baseline creatinine was in the 1.2 to 1.4 range, increased recently to 2.1 milligrams per deciliter after hospitalization for COVID-19. So again, this was in that 2021 period. And this patient had confirmed APOL1 G1, G2 genotype high-risk alleles. At the time of kidney biopsy, she had creatinine of 1.53 milligrams per deciliter, GFR 41, and proteinuria that was above 3 grams. Kidney biopsy showed focal, global, and segmental glomerulosclerosis with some collapsing features. Interstitial fibrosis, tubular atrophy were moderate, with some arterial sclerosis, moderate to severe, was the semi-quantitative reading. So, we've heard a lot about the mechanisms of APOL1 induced injury, from ion channel formation, inflammasome activation, ER stress, lysosomal dysfunction, etc. And I think it's going to be important going forward as we tie this up to really understand the mechanisms, right, that are at play in disease pathogenesis for individual patients, so we can offer the right treatment. And we heard a lot about the phenotype in Dr. Friedman's talk earlier this morning of APOL1 null alleles. And again, this was another report by the group at UPenn showing patients with APOL1 null alleles not having kidney disease, right? Really normal BUN creatinine, blood pressure, urine albumin creatinine levels being similar to patients with wild-type APOL1. So again, APOL1 not essential for normal kidney development or function, reassuring us that we could inhibit the function or expression of APOL1 therapeutically. And of course, there are a number of therapeutic targets that are being pursued, including a few that we'll briefly touch on today, manipulating the JAK-STAT pathway, inhibiting the function of the channel capabilities of the mutant APOL1 protein, as well as other approaches to come that could reduce expression of APOL1. So again, just an overall summary of how some of these agents may work, including baricitinib, JAK-STAT inhibitor, as well as inhibitor of the channel properties of APOL1 that you heard more about. So we'll talk a little bit about the inaxaplin data. Again, this was previously shown. There's great target engagement of inaxaplin in inhibiting thallium ion flux in the upper left, and that's certainly upregulated by the mutant APOL1 protein on the right and reduced by the small molecule inhibitor, which also reduces albuminuria in a mouse model of APOL1 overexpression. And, of course, we've seen nice work from Dr. Olabisi, again, showing the role of inaxaplin in inhibiting ion flux. And again, potassium transport is certainly something that's upregulated by the mutant protein, which will lead to membrane hyperpolarization and perturbations in intracellular calcium that can be enhanced, increased calcium release from intracellular stores. So again, the small molecule could inhibit that pathogenic ion flux that could lead to cellular homeostasis being preserved. And of course, in the phase 2 trial, patients who received this inaxaplin small molecule inhibitor single-arm study had a notable reduction in proteinuria over 13 weeks. Again, not a randomized controlled trial for this phase, but the phase 2-3 study is ongoing, which is itself randomized. So these patients, again, had biopsy-proven FSGS. And you can see from the baseline data, the majority of patients here had subnephrotic levels of proteinuria, but again, 3 did have higher levels. They overall achieved a significant reduction, about 48% reduction in proteinuria in both the subnephrotic and the nephrotic range proteinuria groups. And it was generally well tolerated with some, mild GI, headache, back pain side effects reported, but generally overall for this 13-week period, well tolerated. So what are some other approaches to APOL1 inhibition? Well, again, Dr. Olabisi is way too busy, it seems, down in North Carolina. Very nice work here, JCI Insight, showing that the COVID-19 cytokines can drive APOL1 expression, right, in human organoids. In, again, this case, a patient with APOL1 high-risk alleles, really a nice illustration of upregulation of APOL1 in that patient with high-risk alleles, which was inhibited by baricitinib, a JAK-STAT inhibitor. And of course, the viability of podocytes that were derived from these organoids could also be preserved. You can see really a nice preservation of cell number with baricitinib treatment of these podocytes, whether they were treated with interferon or all cytokines to cause injury. This was a rescue with baricitinib treatment. So that's, again, another potential approach to patients with these high-risk alleles and a phenotype. Another approach is reducing the expression of APOL1, right, with antisense oligonucleotides. And this was one JCI Insight paper in 2019, again showing in this mouse model, APOL1 G1 mouse, urine albumin creatinine levels upregulated in the vehicle-treated mice on the right with antisense oligonucleotide treatment, reducing the albumin creatinine ratio in these animals. And of course, Dr. Shustak also showed a similar approach with APOL1 antisense oligo, again reducing expression of APOL1. You can see on the left in Western blotting, and on the right, this antisense oligo 1 preserving the morphologic architecture, right? Histology, certainly glomerulosclerosis being reduced for ASO1 shown here. And we heard as well about the protective variant, right, the N264K risk variant. Again, that's been shown with in vitro studies to protect, right, against cytotoxicity, right, in G1 and G2 associated cellular injury, which you can see. And again, very nice work by Simone Sanacerci showed that this protective variant is inherited with G2, so either with the G1, G2, 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 high-risk genotypes, but it, again, based on in vitro studies, you get protection against G1-mediated toxicity. And in a Jason study, it was published as well, looking at the Million Veterans program, the Vanderbilt Biobank, and all of us. You can see that the risk of chronic kidney disease and end-stage kidney disease is reduced in patients with the high-risk variants if they also have this protective variant. So blue is the protective variant and red would be the high risk. So when you have that co-inheritance, you have a reduction in CKD and end-stage kidney disease. So, again, complex milieu we're kind of going through with the different ways of APOL1 causing cellular injury, from cytokine-mediated upregulation, cation transport, mitochondrial ER stress, a lot of mechanisms we didn't have the time to touch on today, and also post-translational modifications that may occur. So I do agree that we're looking at multiple mechanisms of injury, and it will be important as we decide on therapy to take this into account. Really back to our last patient. This patient actually was in the Vertex phase 2 study. And responded quite well. So she was one of the 13 individuals in that last analysis. You can see in the yellow bar what happened to the urine protein creatinine ratio during the treatment period. She really went down to really low levels of proteinuria. In the last 12 months, she's been consistently less than 0.4 grams per gram, GFR stable at 30 to 35 mLs per minute, but she's taking, a lot of other medications, right? So after the 13 weeks in the study, she came off and has not been on the drug. She's taking losartan, max ARB dose. She's on a GLP-1 receptor agonist. She's been on that for over a year now, and she's on spironolactone as well. So several antiproteinuric agents are on board as well, which will be important as a part of maintenance therapy going forward. So just to conclude, APOL1 diagnostic approaches are expanding, and they benefit certainly from point-of-care rapid result turnaround. Therapeutic options with different mechanisms of action are being developed in the context of clinical trials, channel modulators, antisense oligonucleotides, modulators of the protective APOL1 variant are certainly a part of the approach being developed, as are other approaches that may come in the future, including CRISPR-based gene editing, etc. Remaining questions exist around the mechanisms of APOL1-induced injury, and precision-based approaches to treatment and optimal supportive care frameworks really need to be better understood. So with that, I'll pause and happy to answer any questions you may have. Dr. Shustak.
Amazing talk. I really enjoyed it. In your mind, first of all, I think the Vertex study is really amazing as opposed to genetic medicine, because even though I am, teaching this, it's kind of difficult to really make sure that the genetics that start, when you're born, it's still in operation, I don't know, at 50 years of age when the disease is already happening, podocytes are less and fantastic.
Right.
But on that question, in your view, when we should intervene? Is it still good to intervene when, the creatinine is 2? And then I was also slightly surprised by your patient 1 with the albuminuria of 99 milligram per gram, because, we started to dabble into clinical data, and then it seems that if you have even a little bit more albuminuria than normal, like close to the upper end of normal, it's probably not good. So I'm curious to hear your insights.
Sure.
When to intervene and the albumin.
No, absolutely, yeah. And again, it sort of, we need more evidence to really guide this approach. But you're totally right. A patient has the high-risk genotype. We know from a lot of studies in Fabry's disease and lupus, etc., that histologic changes happen before the clinical manifestations. Patients certainly can have podocyte injury before albuminuria, proteinuria, kidney function changes going forward. So I think that is an open question. The other issue is, as we know, we always say in the U.S., 90% of patients with chronic kidney disease don't know they have it. So even taking a step back, identifying patients with albuminuria, proteinuria, and preserved kidney function may be the best place to start, right? Because those individuals certainly have ongoing evidence of injury. And again, this UPCR 99, again, technically that's within normal range. The USCR, totally normal as well. But again, to that point, is there a subclinical injury happening, at the structural level? And this is where non-invasive biomarkers, right, are going to come in really handy to help guide us. Because the patients, again, and this is part of the breakout group session, you could have an individual, APOL1 high-risk genotype, maybe normal protein creatinine ratio, but if they have, a biomarker, right, panel that suggests that they're very high risk for progression, those are individuals maybe we should treat earlier, right? So again, that's a research question that we certainly hope to answer.
This is just more of a comment, but I would make a plug for measuring urine albumin and creatinine rather than urine protein and creatinine, especially in those low ranges, right? Because 99 could be a urine albumin and creatinine of 60. We don't know. So
absolutely. Yes.
Me? I'm Kate Bram, I'm from London. Thank you for that amazing talk, and so inspiring and exciting that there are these novel agents available. I'm going to do that really annoying thing and ask you 2 questions. Apologies. Number one is just to kind of come away from the novel therapies and think about the pre-existing therapies. Right. Obviously, major breakthroughs in our CKD management over the last kind of 5-10 years. Do we think, as a community, just to put it out there for our recommendations, whether or not we should be really requiring that future trials and pre-existing trials should be reported according to APOL1 status, because we just don't know, do we, if SGLT2s are as effective. I hope they are, but so that's question number 1. And then question number 2 is about, because of the historic challenges with having representative proportions of people of African ancestry in trials, I'm really concerned about some of the new medication therapies coming on the market triggering APOL1 disease. And again, whether or not we need to be, as a community, collecting those data, like HIF stabilizers, for example, could be damaging. I don't know yet, but just to put it out there, whether or not we should be advocating that these are a really important group of patients that we need to be really understanding all therapies, not just new therapies for.
Well, the thing I like is that both questions were closely related, so I can sort of group them and answer in one. So that's really great. No, but I definitely agree, and it kind of goes to the historic underrepresentation of patients of African ancestry in clinical trials in general, and especially in nephrology clinical trials. And we saw in sort of a composite of some of the major studies, and we've had some real breakthroughs in the nephrology space in the last 10 years or so. If we have 10% of the study population, right, being of African ancestry, that's considered great, then we know that it's not good enough because of the overrepresentation of these individuals in the clinical population. So if we again extrapolate and assume that maybe 14% or so will have APOL1 high-risk alleles, really getting to a small fraction, right, of individuals with APOL1 high-risk alleles in these trials. So definitely agree that we need to do better at advocating, certainly for representation of diverse populations, but also banking, right, these DNA samples, right? If we have certainly rapid turnaround tests, we can certainly incorporate that into study protocols, but at least being able to go back, right, and see the safety, efficacy signals based on APOL1 genotyping will be invaluable. I totally agree. Yes?
Excellent talk, Dr. Campbell. I wanted to go back to your work with the GUARD study.
Right.
In St. Louis, we've been establishing a cohort. We've enrolled 275 patients for genotyping and looked at their attitudes about testing. And a high proportion reported that they would be interested in having family tested, but when we opened it up, we actually didn't get that many referrals. So just wondering about your experience. Did testing patients lead to broader testing of family members, and what was sort of the impact on the broader community?
No, I think that's really an excellent point. Certainly it's a lot of education outreach required, right, to engage populations who don't traditionally participate in studies like this, right? So really having a strong patient voice embedded within study design and outreach and stakeholder board, community advisory board groups has really facilitated a lot of family outreach, community outreach for family members to be tested. And I think, certainly when, the heterozygous or homozygous high-risk allele data are certainly presented, that raises certainly the concern and the desire we found for patients to be tested, or even the reassurance that the high-risk alleles are not present. So I think studies like this are invaluable. Again, raising awareness about the contribution of this high-risk genotype to CKD progression, but also raising awareness about chronic kidney disease in general, right, and getting more folks tested for kidney disease. So definitely agree. Appreciate it.
Thank you very much, Dr. Campbell.